Therapeutic custom ablations are indicated for special cases where visual acuity with glasses or contact lenses is not satisfactory. In this video, we discuss therapeutic ablations as an alternative to corneal transplantation that must be differentiated from elective refractive surgery, and show representative cases of therapeutic ablations that represent our daily practice. The use of the excimer laser in PTK mode is essential for therapeutic refractive surgery. However, therapeutic ablations also involve topo-guided and sometimes wavefront-guided custom ablations. Mitomycin C has dramatically improved the predictability of the wound healing response for most of these procedures, which are performed as advanced surface ablation. Epithelial scrape with the excimer laser in the PTK mode is critical since epithelial thickness is not regular in these cases, and we need to reproduce the same stromal surface as was measured preoperatively with the intact epithelium. A large ablation diameter is critical, such as in the Allegretto IQ platform, which goes up to 9.8 mm in diameter. PTK is also applied with a smoothing agent, such as diluted Helon, artificial tears, or even BSS. Some cases with a cleavage plane between the scarring area and the subsequent corneal stroma require superficial keratectomy. Front elevation data from placebo disc or Schimmelflug imaging allow for a customized topography-guided ablation. The goal of TCAT is to regularize the corneal surface, which typically takes less tissue to treat ocular aberrations. Also, these cases cannot be measured with Hartmann-Shack or Cerning aberrometry. When evaluating the cornea, it is crucial to rule out ectasia and should go beyond anterior corneal surface topography, which may resemble or masquerade as keratoconus due to the irregularity of the ocular surface. Tomographic and biomechanical testing is critical, like in this first example of a corneal scar after keratitis related to contact lenses with myopia and irregular astigmatism. The thickness profile is normal, as is the ORA parameters and the new Corvis Dynamic Ultra High Speed Schimmelflug imaging exam, which demonstrates normal deformation amplitude. Even though placido disc-based topography does not provide the complete picture to rule out ectasia, it does enable the evaluation of the tear film. That is, it acts as a non-invasive tear film breakup time test. Corneal opacities and surface irregularities due to multiple causes represent the most common indications. We must, however, differentiate if vision is impaired because of the irregularity of the anterior corneal surface or due to the corneal opacity. In many cases, the regularization of the anterior corneal surface allows patients, even those with deep corneal stromal opacities, to have a significant improvement in vision. Like in the first example, which improved from a best corrected vision of 20/40 to an uncorrected vision of 20/25 1 month after custom topo-guided surface ablation with PTK for epithelial removal. Complications from previous elective refractive surgery are also common indications, including keratectasia, since customized surface ablation may be combined with corneal collagen cross-linking. Canalopoulos has demonstrated that custom ablation followed by cross-linking in the same day is the best approach, which he named as the Athens Protocol. This protocol is getting more and more popular for treating keratoconus and keratectasia. This case with bilateral ectasia after LASIK was treated with significant improvement on corneal tomography, which is consistent with the improvement in vision in both eyes. Interestingly, the cornea is thinner after the procedure, but the Corvis exam demonstrates higher biomechanical stiffness and stability. This 80-year-old diabetic male patient with granular corneal stromal dystrophy and advanced cataract had a best corrected vision of count fingers at 1 foot in both eyes. The ocular ultrasound was normal. A triple procedure was considered but was eventually not advised due to the patient's poor general health and a history of age-related macular degeneration. Based on the patient's tomographic findings, we proceeded with a combination of therapeutic PTK and TCAT PRK with mitomycin C. 2 weeks later, cataract surgery with intraocular lens implantation was performed. The postoperative anatomical corneal outcome was excellent, but the overall vision was limited by an AMD scar. This 16-year-old female with progressive worsening of vision in both eyes due to Reese-Buchler anterior corneal stromal dystrophy. She had an uncorrected vision of count fingers at 1 foot and a best corrected vision of 20/80 in both eyes. Transepithelial PTK was initially used for epithelial removal. With the slit lamp attached to the allegretto, we observed with the slit lamp attached to the laser a significant degree of stromal irregularity, and thus decided to not proceed with TCAT, which was initially planned, but to repeat PTK with BSS as a masking agent to regularize the corneal stromal surface. Mitomycin C at a concentration of 0.005% was applied at the end of the ablation, followed by copious irrigation with chilled BSS. A similar procedure was performed in the contralateral eye. 1 month after the procedure, the patient had a best-corrected visual acuity of 20/30 in each eye with residual myopic astigmatism that could be now treated as an elective refractive surgery case. This case had bilateral idiopathic band keratopathy with anterior corneal stromal scarring. The calcified layer was debrided from the rest of the corneal stroma using an insulin needle-based superficial keratectomy technique to find the plane of cleavage. After that, we used PTK with BSS as a masking agent to smooth the anterior stromal surface, followed by single application mitomycin C use. The patient improved their best corrected visual acuity from 2200 to 20/30 in each eye. This case is a 46-year-old female patient who had a flap complication during LASIK surgery in her right eye. It required 3 retreatments. In contrast, her left eye had a relatively satisfactory result after LASIK surgery. In her affected right eye, central cornea thickness was 348 microns, and a total wavefront analysis obtained by a ray tracing system of individual points revealed residual hyperopia with astigmatism and high levels of high-order aberrations. In the affected eye, uncorrected visual acuity was 2200 and best corrected visual acuity was 2070. On slit lamp exam, we observed a central anterior stromal opacity, which was also well characterized by Schimmelflug-based tomography. Considering the thinness of the cornea, we proceeded with surface therapeutic ablation with mitomycin C use. The patient's cornea is still biomechanically stable at 3 years after surgery with a central cornea thickness of 256 microns. Uncorrected visual acuity is 20/40 and best corrected vision is 20/25. Along with a number of similar cases reported by Paolo Vincigura, this case illustrates that the post-LASIK cornea can still be stable despite an extremely low central corneal thickness. An individualized and customized approach is recommended for every case of therapeutic ablation, which provides very satisfactory outcomes for patients and surgeons. Thank you for your attention.